Introduction. Heart failure is a global pandemic with the increasing prevalence. Drivers of the growing prevalence of heart failure are aging of the population, improved survival after myocardial infarction, and improved treatment and survival of patients with heart failure. Heart failure is the leading cause of hospitalization among adults, and 1 year mortality is 10 to 35% across various studies and registries. Heart failure-related hospitalization costs are estimated to be about 30.7 billion in 2012, and it is estimated to be, it is projected suggesting that it is increased by 127% by 2030. So heart failure phenotypes has been classified by the ESC in 2016, where the mid-range EF was as a new group of heart failure which has come up, and it got updated in 2021 as a mildly reduced ejection fraction. From then on, clinical studies devoted to heart failure with mildly reduced ejection fraction have rapidly emerged. And need for the study. Results of studies of heart failure mildly reduced ejection fraction are not consistent and are sometimes contradictory, suggesting that mild reduced EF may have complex characteristics. Current understanding of the mild reduced is still insufficient and lead to debate about whether mild reduced EF is a unique subtype of heart failure or a transition stage between reduced and produced EF. And there are only few studies on Indian population. Therefore, this study was undertaken to explore the clinical characteristics and progress of heart failure with mildly reduced ejection fraction. And my primary objective was to estimate the proportion of heart failure with mildly reduced ejection fraction in acute heart failure. And secondary objective is to study 1 year rehospitalization rate for acute heart failure and MACE events, and to study 1 year mortality among heart failure with mildly reduced ejection fraction. And it is a prospective observation cohort study of consecutive patients presenting with acute heart failure and recently discharged from hospital with acute heart failure. And it was done in an outpatient study in the Department of Cardiology for a period of 1 year. And patients aged more than 18 years and confirmed cases of heart failure according to Framingham heart failure criteria were included in the study, and patients who were not giving consent and uncompliant for follow-up were excluded from the study. And sample size, it was calculated based on the CSA Kerala acute heart failure registry, which is done by Dr. Shriji Joseph sir, and where he has given the prevalence of 17.8%. By substituting that is in the formula, we got the sample size of 230. And the method of data collection, baseline characteristics of the patients was collected at enrollment using a structured performa. Participants were stratified into reduced, preserved, and mildly reduced ejection fraction group according to their LVF, which is measured by Simpson's biplane method of DISC using a Philips Epic Q7 machine. Follow-up was done via telephone and outpatient service, and data was collected on symptom status and clinical events, all-cause mortality and cardiovascular mortality. Deaths and their cause was recorded by review of the relevant medical documents. When not documented, it was obtained by contacting patients, physicians, or relatives. Data was collected also hospitalization for major cardiovascular events, and LVF was reassessed at the end of 1 year. And statistical analysis was, data were entered in Excel sheets. Analysis data was done using statistical software SPSS, and quantitative and qualitative variables were expressed by mean standard deviation and proportion, respectively, and significant level of 95% confidence intervals determined for all analysis. And coming to my results, out of 230 patients, 59 patients, that is comprising of 25.65% of patients were in the range of heart failure with mildly reduced ejection fraction group. And our study is comparable to most of the national and international registries, but in my study it is a little bit higher, right, which I attribute to because mine is a single center study. And these are the baseline characteristics of the samples at the time of enrollment, like age, women compression of women, and other comorbidities. And this is symptom analysis, and this is the etiological heart failures. And the key characteristics in the samples are heart failure with mildly reduced is 25.6. And the mean age is 59.6 with 14 years of standard deviation, which is a decade younger than the developed countries. And male predominance was seen in 76.3%. Dyspnea is the commonest presenting symptom in 93.4%. Systemic hypertension and diabetes were the commonest risk factors. Ischemic heart disease, which is comprising of 74.57%, is in the commonest etiological factor. And the ECG analysis, it was LVH and LBB are the commonest findings seen in the 5.5%, and AF is seen in 5.1%. But it is less compared to the other registries, which I will attribute because of it is an outpatient-based study, and in other international studies, they use the devices for diagnosing the heart failure, atrial fibrillation. And the rehospitalization rate, overall rehospitalization rate was 52%, and in that 35.5% is contributed by the heart failure itself. And for 11.9% is for ischemic events, and for 6.8% for stroke, and 3.4% for ventricular tachycardia. And it was higher as compared to the Kerala heart failure registry. It is because it is 1 year follow-up study in my study, and it was a 90 days follow-up in Kerala heart failure study. And all-cause mortality was the 13.6 out of 59, 8 patients died. And in that 6 patients were died because of cardiac mortality. In that 3 were because of recurrent ischemic events, and one is heart failure, one is because of stroke, and one died because of VT. We suggest that the patients will develop even mild also will develop VT and cardiac mortalities. And at the end of 1 year, the LVF, it was 30% of people went to the went to reduced CF group, and 45.7% in the mid range, and 23.7 in the preserved group. It is more in reduces because of recurrent hospitalization. The concludes heart valve is not simple. It seems LVF changes dynamically with the improvement or deterioration in the patient condition, and it resembles a container for a crowd of patients. And because of this, gap needs to be filled with the further studies. And I used to recommend about guideline-directed medication should be available in all hospitals in the public sector, and rehospitalization should be done. And my study limitations is on small sample size, which is observation study, hospital-based study performed at a single center, and therefore does not represent all heart failure cases in the community. Heart failure in children and adolescents are not included. Heart failure days of predates were not followed up. Thank you.